Welcome to the Matcha Guardians podcast, brought to you by Matcha.com. Here, we focus on the biggest trending health topics of our time, featuring the greatest and upcoming wellness advocates. Now, here are the Matcha Guardians. Licensed dietitian Diana Weil and medical journalist Elara Hadjivateris.
Hello, everyone. Welcome back to another episode of the Matcha Guardians.
So this week we have a very exciting and special guest, an addiction psychiatrist and also the medical director of alcohol and drug inpatient treatment at McLean Hospital in Boston, Massachusetts, Dr. Matthew Mosquera, who also happens to be my brother, if you guys can't see the resemblance, striking resemblance to the eyebrows. Welcome, Matt.
Hi, everyone. Thanks for having me. Elara and Diana, it's a pleasure. You can call me Matt, by the way.
I mean, it's hard for me to put the title of Dr. Mosquera. Can you call him Dr. Mosquera?
I mean,
Diana's known Matt
I
for
could do
years,
it.
too.
If it was important to you, I could do it. But, right, I've known you since I was 12, 10, something like that.
Yeah, the doctor bit, you don't need it.
The doctor.
But I am a doctor.
You're a doctor. So you're a doctor
Yeah.
who specializes in addiction within mental health. What made you choose that?
I'm trained in general psychiatry, so I do focus on all different mental health ailments, but I got subspecialty training in addiction. I was after my residency training, but I guess where should I start? What led me into medicine first or psychiatry?
Psychiatry within medicine is what I'm interested in knowing.
In the world of medicine, there's all sorts of different specialties, as everybody knows. And going into it, I knew I wanted to go into something where I could sit down with folks, get to know them, figure out what makes them tick, figure out how to help make them better. That's simple. And I thought I was going to go into neurology at the start. And you do all these different rotations in med school. I rotated in neurology, and it wasn't what I thought it was going to be. For a lot of different reasons that probably aren't pertinent here, I wasn't drawn to the field. You don't get to sit down with folks as much. You don't get that strong, deep connection that I was looking for. And it turns out that connection that I was looking for was actually present in psychiatry. So when the time came, I did my psychiatry rotation. I absolutely loved it. I did a bunch more throughout med school. And then I decided on going into training for psychiatry.
Off the top of my head, one of the things that strikes me, right, with psychiatry when you have sessions with patients is you're able to really get a holistic view. You're spending time with them. You're getting to know them versus a lot of other specialties. I just think about when I go to my OBGYN or my general practitioner, I'm spending at most 10 minutes with them. And we're just kind of going over vitals and things like that. And they're filling out, forms on the computer, but we're not really ever having a conversation. Or if we are, it feels very surface level, very topical.
Completely surface level. You don't get to get down to the nitty gritty, which is what drives me. It's kind of what I went into it for in the first place. Unfortunately, medicine these days is more disease management, kind of churn and burn model. It's kind of impersonal, which is not what I like. So, hence psychiatry.
One of the things I struggled with was what is the difference between like a social worker and a therapist and a psychiatry on like a day-to-day level?
Great question. To be completely honest here, I had no idea the difference between a psychiatrist, a psychologist, a social work, PsyD, all these different terms all meant the same thing to me going into it. So let's break it down. So a psychiatrist, medical doctor who just has a specific training in mental health. So we can do therapy, we can prescribe meds. Psychologist can focus on any different element in the world of, human psychology, everything from they can focus on therapy to research, everything in between. They can't prescribe, but boy, can they do therapy, and they're typically some of the best therapists out there. Social work, they wear a lot of different hats. I work with social workers here on our inpatient unit, and they are an essential part of the team, helping to meet with patients, connect with families, set up aftercare. But then they can also do therapy on the side. And in addition, there's all these different other sort of sub-qualifications like licensed mental health counselor. They can do therapy. Life coaches can do therapy. The licensure for it is quite broad. There is no specific license to be a therapist. You can come at it from a bunch of different angles, which is cool. There's definitely a lot of pros to it and some cons as well.
So within the mental health field of psychiatry, at least like within your specialty of addiction, what type of conditions are you often treating with your patients? Like what are the, top 3, top 4 things that you've been seeing a lot over the last year?
So different substances like opioids, cocaine, meth, they probably get a lot of the headlines.
Yeah.
But by far and away, the most common thing that we treat here at McLean in our program is alcohol use disorder. We don't call it alcohol addiction, we call it alcohol use disorder. Get into that if you guys want.
I do want.
And in the world of psychiatry, it's the world of medicine. I believe that language is important and being precise in it. And sometimes when you just label something as an addiction, it's a little bit vague, there's a lot of stigma attached to that word, when in reality, we're treating use disorders, right? People use substances for a reason, good and bad. And when that use gets in the way of their daily functioning, then we're going to start calling it a use disorder, as opposed to an addiction, because it's just addiction, it doesn't carry as much clinical meaning. So that's the terminology in the biz right now.
Alcohol use disorder. Okay, so that's what you guys are seeing primarily the most of?
Yeah. Whenever it comes to somebody that has a problem with the substance, it's a use disorder.
And then you said also on top of that, opioids,
Yep.
methamphetamine. What about a word I've been hearing about lately is ketamine. What is ketamine and where is its role within mental health and like possibly being used for treatment instead of using methamphetamines and using cocaine? Like it's actually good to possibly use ketamine?
Yeah, so ketamine is this up and comer, but it's actually been around for quite some time now.
It's a force tranquilizer, right?
I'll give you a whole talk just on ketamine. So ketamine, and we can get as technical as you want or as surface level. So I'll just kind of give my 2 cents. So ketamine was created in the 60s by this pharmacist, Dr. Calvin Stevens. I just know because I just did a presentation on it by this big pharma group. And it was really a new and improved version of, I kid you not, PCP. And they created a drug that they wanted to be able to give folks pain relief as well as provide anesthesia. And they kind of nailed it when it came to ketamine. It has an anesthetic agent to put people under. It's really great because it has a short half-life, meaning it comes in and out of the body relatively quick. We understand its pharmacodynamics, basically how long it lasts and what it does. And it doesn't tank our ability to breathe. So it's great, actually. And then it also helps us with pain control. It was only kind of recently that we started looking into it for more treatment-resistant depression and other avenues like substance use disorders. That's all come of age from like 2015 and beyond. It got FDA approval for treatment-resistant depression, I think in 2019. There's this nasal spray called S-ketamine. And now it's really exciting and cool. The last couple of years, a lot of different research groups have started looking into it for use in treating substance use disorders, or some people call it addiction. As far as how it works, that's a whole another topic.
What do you see as the pros or cons of using ketamine? I mean, it's being kind of touted right now as this like amazing miracle drug, but I'm sure that there's also some cons to it, correct?
There's definitely some cons to it. And you can abuse it. It's not one of the more abusable substances out there, but it certainly has abuse potential. And then even if you're using it as prescribed, folks taking it on a regular basis get what's called the K cramps, like their stomach gets crampy, and it can affect the urinary system as well. But for the most part, it's relatively safe. That's why it's. I think there is going to be a role for ketamine for years to come in the world of psychiatry, mostly because it works quickly, and like most of the meds we have, most of the treatments work slowly, and ketamine is atypical in that the mechanism by which it helps us to improve our mood and be more receptive to behavior change is way faster than most other meds that we do.
But do you have to keep taking ketamine regular, or is this kind of like you just take it once and then you're going to feel better for like 3 months?
So the jury's still out on that. It's a really good question. We don't really know for sure. There hasn't been like any one study to be like, okay, if you have this type of depression, you take it for X amount of time.
Yeah.
That's not proven yet. So a lot of times if folks get connected to ketamine clinics, they have super bad depression, they'll get started on it 3 times a week. And then their depression hopefully gets better. And then maybe they go on to what's called a maintenance dose, and they'll get it once a week, once every couple weeks. Each patient is different, so that schedule is going to be variable. But when it works, it really does work. I just chatted with someone this morning who is really bad depression for the longest time. She got plugged into a ketamine clinic, has been doing, I think, ketamine lozenges. Not the norm, but still effective, 3 times a week. And she said it's been life-changing. Her depression lifted, and now she's able to function better than any other SSRI or antidepressant she's tried in the past. So it was cool. Just this morning, I chatted with someone, a 26-year-old woman.
Huh. So would you say that there's a bit of a correlation between substance use disorders and people struggling with depression? Like that there's a strong connection there, like people are kind of placating their depression or self-medicating?
Yeah, absolutely. So I think we just hit on this thing called in the visual, the self-medication hypothesis,
Okay.
which is kind of self-explanatory, right? People use substances for a reason. One of the questions I first ask my patients, whether it's in the hospital or outside the hospital, is like, what are you using and why do you use it? The good and the bad. And people will typically be able to rattle off a few different answers in either camp, the pros and cons, what they like and don't like. So there's a huge overlap between depression and substance use, right? Doesn't feel good to not feel good. So you want to try things, make yourself feel better. And if medications aren't hacking it, if what you try behaviorally isn't hacking it, you're going to maybe try some substances.
You mentioned that like ketamine clinics for people with really bad depression, this isn't something that you can just go to your local psychiatrist and be like, hey, I've heard ketamine can be useful. Like, how do people get started on ketamine?
You know, Matthew Perry from Friends was taking ketamine regularly, wasn't he? I mean, he ended up,
Is that what he died from?
I don't know if that's what he died from, but I know that he was regularly going and taking ketamine, right, Matt?
Yeah, so to start on ketamine prescribed by a physician and not just bought on the street, you have to get connected to a ketamine clinic because there are some strict regulatory elements to it where if a clinic wants to administer it, they have to keep it under lock and key, record the specifics of how many doses they've given out, etc. So just your bread and butter psychiatrist would have to get certified to be able to provide it. So yeah, Matthew Perry is a good example. I think he was quoted as saying that ketamine really did help him, kind of similar to the patient I mentioned earlier. Unfortunately, he did pass away. And my understanding was, I think ketamine may have been in his system, but a whole bunch of other different substances. So ketamine, I will say that if you combine it with other depressants, it's risky. It's not going to make you stop breathing, but some of the other stuff, man, I think that may be what happened to him.
So going back to the questions that you ask patients, right? You ask them what substances do they use and why do they use it? What are usually some of your like follow-up questions that you ask?
What do you like about it? What do you not like about it? Do you view it as a problem? Invariably, if folks coming to me, they'll be like, yeah, here's a problem. No duh. And then I'm like, okay, what do you want to do about it? And I'll leave it in the open. I'll leave some space, some silence. And then typically I get a response. If not, like, do you want to stop using it? Do you want to cut down on your use? And this is where the term ambivalence comes into play. Almost always there's some degree of ambivalence. And I remember when I first heard that word, I'm like, what? I'm not sure there's a disconnect, but a big word. I'm like, how does it really apply here? But it really just means that folks are sitting on the fence. Like part of them wants to stop, part of them doesn't. And it's like that war playing out internally that I try to tease out. And then we try to lean more on the side that's telling them, hey, I got a problem. I got to do something about this. Cutting down a minimum or hopefully stopping at least for a period of time.
I feel like in the addiction world, there's this idea that once you're an addict, you are always sort of an addict or you're always in recovery. What are your thoughts on that kind of, maybe even just the terminology around that, or just that idea that like once you're an addict, it's always something that you're going to struggle with?
Yeah, it comes up a lot. Dovetailing into that kind of topics like stigma and shame come to mind. A lot of what keeps folks from accessing treatment for a substance use disorder is fear of that label that you mentioned, Diana, and then the shame that comes with it. So what do we do about it? And as far as it being a lifelong thing, it kind of depends on the person's mindset. Sure, there are going to be people out there that once you're labeled an addict or a user, that's going to stick with them for life. Other times folks would be like, look, I had a substance use disorder. It's now in remission. I got to stay vigilant. It's a chronic condition, but it doesn't define who I am. So it depends on what mindset they adopt. But it's central to a lot of the treatment and coming in and out of treatment and interacting with family.
Well, I would say from just personal experience, right? I went through a phase, I guess that would probably be defined as substance use disorder when I was in college, the era of binge drinking and maybe trying different substances, not taking care of your body for a good amount of years, like probably, 5 to 7 years. But at no point in time did I ever think to define myself as having any sort of substance use disorder until after the fact, almost 10 years later, right? And I just kind of consider that more of like, that was a phase in my life. I experienced it and I left it there. And now I'm in this new phase of my life.
Yeah. It can be hard in the moment to recognize you have an issue with something if you're not experiencing negative consequences. Right? Because then you're like, what the heck? That's just fine. Nothing bad is happening in my life, but then something may come to the front. And then hopefully at that point, when you recognize that like the consequences are there, that it's not really serving you well, that you do seek treatment. Yeah. And personally speaking, so it's maybe a little bit of a dark term, but I'll go into it. So I had a best friend in high school, who Elara was friends with as well, who super high functioning, went to a great college, name's George. Her name was George. Some bad foreshadowing there, but George, after college, got mixed up in opioids. And I really wish I know now what I know now then, to be able to help him better, but it mixed up in opioids to a pretty severe degree. And I remember this conversation I had with him, like, hey, what's going on? Like, he was so smart. He recognized the negative consequences, like I mentioned, that it was wreaking havoc on his life. But it was actually the shame of admitting that he had a problem that kept him getting into treatment earlier. And he eventually did get into treatment, was able to achieve a couple of years of abstinence, and then tragically relapsed and passed away. But I'll never forget him and his amazing friend, but also just that conversation we had about the shame about using and getting into treatment. So the stigma is huge. It is a topic that gets talked about, but it's like the elephant in the room whenever we're talking about.
I mean, so many people also deal with it. It was one of my questions for you, was that now that you kind of are a trained psychiatrist, you are a trained psychiatrist, do you feel like you walk around now being like, oh, there are all these people in my life who have maybe issues or substance abuse problems that you didn't recognize before?
Hopefully I'm more like keen to it. I pick up on things. I guess the things that I pick up on, okay, somebody's using this. They're drinking a bunch of alcohol, or they're smoking a bunch of cigarettes, or doing a bunch of cocaine. Okay. All right. That's happening. I'll recognize it. And then I'll be like, is this really an issue for them? In all seriousness, to any of those, I'll be like, is this really having a negative impact on their health? Of course, with some of the quote unquote harder substances, always an overdose risk, but I'll always be like, is this serving them well? Or is this not? Because the one thing that I've learned through all my time in training is that our powers as MDs, as physicians, are so limited. Like, I do not have a magic wand, magic powers. The meds we have are okay at best. It's really more the guidance we provide and being okay when things don't go according to plan.
Now, do you think that people can use substances in a positive way, right, themselves? So I think one of the popular things over the last 5 years, once again, speaking from a little bit of personal experience, is psilocybin, magic mushrooms, doing a little bit of microdosing once in a while, taking some magic mushrooms, going out in the woods, is that something that can actually be really beneficial, that people can handle themselves without having any guidance? Because I do think that that's more common these days than not.
Yeah, it's a cool topic. I'd love to hear your guys' thoughts on this, but I think the answer is yes. I think there is a world in which you can use substances responsibly where there are negative consequences in your life. I mean, after all, substances like nicotine, alcohol are legal, but if you use too much in public, you get arrested, right? So there is a happy medium here, and I think the same probably does apply to these newer kids on the block, although they're not new at all, like psilocybin. I think there is a safe way to use it. And it'd be great to get the word out as to how you do that more, because these things haven't really been taught in med school as far as like psilocybin use, ketamine use. So they're all new, and like guidance around it would be much appreciated. So it's something that we could start teaching med students earlier than later.
Do you think there's a push now to start teaching medical students that? Have you seen like more conversations around it?
I think more conversation coming from the med students as opposed to the higher ups. I do some teaching for the med students over at Harvard Med School, and they're just so thirsty for knowledge about all the up and coming treatments, all maybe the new substances of abuse too, and how they can help folks when those patients land on their doorstep. So yeah, the students are pushing for it, which is exciting. So we're trying to work with them to broaden.
Well, yeah, you want to be able to use these different substances, I guess, proactively versus being on the other side of things where you're using it to treat the severe form of depression. You're using it to treat, severe cocaine addiction, things like that. So, putting in guidelines would be amazing, right?
Mm-hmm.
I mean, it's just funny you say that because I didn't even think about that as far as like, if I Google, what's the correct way to use, I don't know, magic mushrooms, like there's not really any official body that speaks to that at all. It's just kind of hearsay. It's just kind of by person, right? Like based on experience.
Yeah. What dose is danger dose? What dose can you feel okay with? What, and what do you have to worry about when you're purchasing these? Because fortunately they're not legalized. So you're invariably purchasing them, now it's from maybe the most reputable sources all the time.
But I feel like that varies so much like by person too. I have a lot of autoimmune people that I work with or people who have chronic pain. And I am so interested in how they can help sort of like my nutrition clients with, sort of these autoimmune conditions. But I obviously can't just tell someone to go off and find some on the streets and like buy magic mushrooms and play around with dose and figure out what works for them,
And everyone is so different, especially when it comes to substances. And like certain substances in particular, people respond to so differently. Like cannabis comes to mind, right? Like one person can smoke same amount of cannabis as 10 of other people. It could be like 10 totally different reactions.
One person gets paranoid, the other person gets really hungry, another person's having a great time.
What's up with that? So I'm not a cannabis expert, but cannabis is more psychoactive than people like to give it credit for. I think once it became more legalized on a national level, we stopped focusing on the potential detrimental effects. Like it hits bunch of different receptors in the brain that are far more numerous than people realize. So it's not as benign as it may have been made out to be. So to answer your question, why? It's also stronger now as far as like the THC content, different strains. There's different levels of THC versus CBD versus all the other, I'm blanking here, I suppose, all the other psychoactive components to it. So it's kind of just become this monster in some ways.
So do you have patients who come in and see and they're like, hey, Dr. Matt or Dr. Mosquera, I should say, I'm feeling kind of depressed. I'm feeling kind of anxious. I'm thinking about smoking some weed. Like, what should I do? And you don't necessarily have guidelines to go off of. So how do you answer a question like that?
Yeah, I tell them weed's probably not the way to go. Sir or madam, just because we don't know how they're going to respond to it. It's pretty risky because of that. They are saying it can make them more sad. So they're anxious, actually increase anxiety or make them paranoid. Sure, you're going to hear from a ton of folks that say, hey, the only thing that treats my anxiety is cannabis. I say, that's great. But have you ever had too much or has it ever made you paranoid? It almost always you're going to hear someone say yes. So right there, you have something that kind of seems to work sometimes. But then you're playing with fire because then it's also led to these maybe not so great reactions. So I can't just recommend that as a sustainable solution. Like I get it. Sometimes it does work, but I'm looking for things that work consistently and have less of the downside.
Sometimes people will say that weed isn't addictive, that you cannot be addicted to weed. But there are people who, for sure in my life that I know that I'm maybe that are very reliant on it. So do you feel like can you be addicted to weed?
Yes. Yeah, that is possible. Yeah. See it a lot.
So you went over you can't, I guess in good faith, recommend weed as a treatment option for people coming in, say, battling depression. Mm-hmm. What are some go-to safe things that you usually recommend? Like one of the things that comes to the topic of my mind is people that maybe have addictions become adrenaline junkies. Right. So you encourage them to work out. Is that something that you often recommend? What?
Two things. I say that. All right. Patient, I can recommend two things that if you do these two things, I guarantee you're going to feel better. This is not rocket science. This is not novel. Daily exercise. And I always start off by saying, you don't got to be a hero. You can just do 5 minutes a day to start out. Seriously, just 5 minutes a day. But if you're consistent, it's going to go such a long way for you. So daily exercise or movement in general of some sort.
Mm-hmm.
And then try your best to focus on quality sleep. We could chat for hours and hours about sleep, but those two things, first of all, they take effort and time. But if you can put in the effort and time for both of them, you will feel better. I guarantee it, which is amazing. Just have a guarantee that you could do two things and feel better.
Well, one of the things I remember you recommended to me, so I went through a stage, as I said, a little bit of substance use in my college years, too much drinking, too much smoking of a couple different substances. And throughout my 20s, I was kind of on and off of nicotine. And I remember one of my favorite pieces of advice that you gave me that stuck with me is that when I have that urge to have a cigarette, let's say it's like 11 in the morning, just wait 15 minutes. Like just kind of delay it. And then it will pass, right? That urge, that need to, have that cigarette in that moment, it will pass if you just kind of push it forward. And that was something that was really helpful for me. The 15-minute window. 15,
if you can wait 15 minutes, great. Sometimes they describe the craving maybe as short as 7 minutes if you can wait. And it's like a wave. You ride the wave out and then hopefully get back down to baseline. And the one thing about cravings, of whether it's a substance, whether it's even food, if that substance, that entity is around you, the availability is up, and availability drives cravings. So one of the things I'll ask people, hey, I want to stop drinking. Great. Sounds good. Let's help you out. Is there alcohol in the home? They say yes. You got to remove it, or else when you get home, your cravings are going to be through the roof. And then it's going to be harder to ride out that wave.
True, if it's just sitting right in front of you.
Yeah. I'd say near impossible.
Another thing I wanted to ask you, Matt, is that I've been seeing a lot of ads for naloxone and a lot of people suggesting that you carry naloxone in your first aid kit. And one, what is naloxone? And two, do you feel like we should all be carrying naloxone?
Great question. I'm really glad you brought it up. So naloxone, also known as Narcan, that's the medication name. It's an opioid antagonist. It's what you give to folks when they are experiencing an opioid overdose. So naloxone, Narcan, it saves lives. I highly recommend that everyone go pick some up. There should be a standing prescription at most pharmacies around the country where you can go in and you do not need a doctor to send a prescription in. It's as if a doctor already did, and you just say, hey, can I please pick up some Narcan? And it's almost always covered by insurance, so at no cost to anyone.
And if you don't have insurance, what would the cost be out of pocket?
That is a great question. If you don't have insurance, you can also they have Naloxone, Narcan giveaways at most hospitals. I would go straight to a hospital then to pick it up, a hospital pharmacy, because they will almost always give it to you for free.
Cool. Thank you. So kind of switching away from drugs more to just more mental health. How do you feel like people are doing right now? Just on how do you feel like
a general
how do you
pulse.
feel like we're doing as humans?
How are we doing? Good given the circumstances. No, people are struggling. They're struggling with a whole lot of different things. Are constantly being bombarded by not so great news, whether it's here in our country or internationally. So it's tough. It's really tough, and people are feeling it.
But do you think part of that has to do with the fact that people are a bit more transparent about their feelings? I just think about our parents' generation to us, and then I think about our cousins and friends that are about 10 years younger than us. And I feel like they're much more open, our generation and the generation below us and below them are just a lot more open about their feelings, right? There's less of that stigma that you talked about, Matt, about being kind of shameful about talking about your mental health and struggling.
Yeah.
So what do you think that social media has played an impact on this?
I think so. I think there's a lot that goes into it. Nice cat in the back for Diana.
Yeah.
All the animals found their way in.
Love it. Where to start here? So social media absolutely plays a part here. Just in general, there's these two topics that come up a lot, grit and resilience. So resilience being the ability to bounce back, and then grit is more like persistence, the ability to kind of push through tough times. And for whatever reason, those are two abilities, let's call them, that are in high demand. You just don't see them as much with some of the younger kids right now. there's a lot of things that play into that. One of them may be the social media part of it, because I think social media, it promotes more isolation than community, unfortunately. I think especially with like the younger users. And with that lack of community, we're kind of having a drop in.
Do you have any general recommendations that you give to parents of people with younger children who around social media use?
Yeah, limit it as much as you can, or at least put it off. I get that, like, now our world is that we are connected. They're going to have some social media use at minimum, but as much as you can, resist it. And I think context is everything. I think kids are smarter than we give them credit for, explaining the reasoning behind it, as far as the downsides and what it may do to them.
Do you have any patients who come in kind of struggling with relationship issues more often than not in the post-COVID environment? Like, I don't know. At least I can speak for myself. I feel like I lost a little bit of my social abilities, just being cooped up for 2-3 years. And I had to relearn certain things. Has that impacted any of your patients? Like, they're coming to you and they're like, Dr. Matt, like, I cannot date people. Like, I am struggling to find a relationship. I'm struggling to connect.
Yeah, I think you're seeing that a lot more, the struggles out there as far as the one-on-one time. I almost view the social interaction ability as like a muscle. If you don't use it, you kind of lose it a little bit. It takes some time to come back. But that's what's amazing about being human, is that we can adapt and get it back. But post-COVID, absolutely. To answer your question directly, I think there's been a lot of challenges, and folks have been feeling it and struggling to get back out there. In some places during COVID, it took the pressure off some people, and then they lost that ability. They're coming back and trying to figure out how to make it work again. It's tough. And then throw in social media, where folks are constantly comparing themselves to some fake version of someone else, and it only furthers our feelings of low self-worth and isolation.
With how people are struggling right now in terms of social connections and news and just everything that's going on right now, how do you make the decision to medicate someone or like offer up medication versus kind of like lifestyle management? And do you feel pressure that when people come to you that they are looking for medication and you have to offer a prescription?
Sometimes, yes. Sometimes patients will be more straightforward than you would expect. Like, hey, I'm coming to you for X substance or X medication, and you have to break it down and slow them down a bit. But by and large, I don't like to throw medications at patients. We'll start a medication if they're really struggling, and different interventions behaviorally, dietary supplements, herbal supplements haven't worked, then maybe I'll go to a med. And whenever I start a medication or recommend anything, let's be very intentional about it. Like, we are going to start X to treat this. We're going to try this behavioral modification to target that symptom. I think if you could be pointed like that, you put yourself in a better position to lose less in the shuffle. Because a lot of folks have all different meds on board, and I don't even know why medication was started after a few years, because it wasn't delivered intentionally.
And then how often are you checking in with the patient, say that you put on medications?
Yeah,
like, are you seeing them weekly? No, it's just different?
When you start a med, you typically want to see someone somewhat regularly, weekly, every other week, at least once every 3 weeks. And then once they've achieved, hopefully, some level of stability, you can stretch those visits out.
How does someone go about, like, if they want to preventatively get ahead of any substance use disorders, like, how often should they be seeing a psychiatrist just to kind of keep their mental health, even if they're feeling pretty okay, like they're content? How do we stay content? Like, how often maybe should they be talking to a third party, a professional? Should it be once a month? Should it be twice a month? Do you have any recommendation to that?
Yeah, that comes up sometimes. Some people will say everyone should have a therapist.
Yeah.
I agree with part of that, and I disagree with part of it. When you're going through a crisis, especially after the fact, sometimes during the fact, it, right? We all go through tough times in our lives. Loss of a loved one, something happening in our life that's super tragic, getting fired from a job. These are crises that meeting with a mental health professional can really help us to navigate way better than we could on our own. So yes, for those folks. But if you're at cruising altitude and you haven't had curveball thrown at you for a little bit and you're feeling okay, you do not necessarily have to meet with a therapist. Sure, a check-in every once in a while could help you, but is it really needed? Maybe not. But some patients, some folks like that for peace of mind. So that's my take on therapy. Once again, I like to be kind of pointed, like, okay, I'm going to see this person for X because I've got these challenges in my life. It's going to make the treatment more valuable. It's going to make your job in the treatment as the patient, because patients are part of the treatment team, easier, as well as the therapist's job easier when you have that stated goal.
How do you know if you should go see a therapist or a psychiatrist? Like, if you, let's say you're struggling, life has gotten hard, you're going through divorce, you lost a job, something like that. How do you pick therapist or psychiatrist?
How do you pick, right? Well, I'm biased, so I always go see a psychiatrist. But no, in all seriousness, sometimes psychiatrists are hard to come by. But if you think like, ooh, this is bad, where I may need to get put on meds as well as therapy, I would suggest then going to see a psychiatrist. But if you're only able to meet with the therapist, someone who can't prescribe necessarily, doesn't have the ability based on licensure, you can start with them and then get plugged in with a psychiatrist afterwards.
Do you have any recommendations as far as how someone should look for a psychiatrist? Like, what's the best way to, is there, psychiatrist.com, like find a psychiatrist near you? What's the best way to find a psychiatrist that's going to work for you?
There is a website called Psychology Today where you can search by your area code, your insurance, or private pay, and punch in the exactly what you're looking for. That's a pretty effective way. I've met with therapists myself, and that's how I've been connected to some in the past. Other times you can go through your primary care. Mm-hmm. And I think, unlike everyone not having a therapist, I think everyone should have a primary care physician to a plug for them. And they can plug you in hopefully with a psychiatrist within your healthcare network.
And after how many therapy sessions do you feel like you can kind of know, because I do think, right, it's a personal thing. You have to have a bit of a connection. You have to have a bit of a trust factor with the psychiatrist, with the therapist that you're working with. After one session, are you going to know, maybe this person isn't for me? And you kind of have to shop around.
Yeah, you do have to shop around.
There has to be some shopping around period, right? At least in my personal experience, it's not always a one-hit wonder.
Yeah, this is where we'll get real. So I was going through a little bit of a life crisis, man. When was this? This was a couple of years ago, on the heels of some relationship struggles myself with some, I hate to use the word, but lack of a better term, toxic situation where I was struggling and trying to wrap my head around what was going on. And at the same time, some struggles in my parents' relationship. So it was a lot to sort through, kind of hitting me all at once. So I'm like, I got to see a therapist. So like I mentioned before, I reached out on the Psychology Today website, got myself plugged in. Simultaneously, I found someone, and that was virtual. Then I found someone in person that I could meet with. And I didn't like either of these people. The first therapist virtually, we were meeting with him. He was well-intentioned. He had a couple of tidbits, but he would turn the camera off, and start eating.
Oh, no, that's not okay.
That's bad.
Respond to the doorbell all the time in session. I think he'll even feed his cat at points. It was like I just happened to be in a session and he was there. So it did not pan out. And that was after they gave him even 3 sessions, but it was consistent.
That is why.
I tried calling him out on it. It just went out for his head. So I'm like, you know what? Maybe not the best fit. And plus it was virtual, and I think I prefer if you're able to in-person therapy, which leads me to therapist number 2.
Yeah.
So I'm meeting with the therapist in person and a little bit older. There's nothing wrong with that. Hopefully wiser, but unfortunately she was hard of hearing. So I'm sitting with her across the room and I found myself, she could not hear me. She kept saying, I need you to speak louder, to the point that I was screaming what was going on across the room just so she could hear it.
And I had these 2 experiences.
It was wild. So that didn't work out. Again, I gave 2-3 sessions and found her to be a great listener, but I'm not sure how much she heard. So then it moved on. It wasn't until I found a therapist one day I'm like, why don't I just check my health insurance, see if there's something there. I was able to connect to a CBT therapist, a cognitive behavioral therapist, via my insurance portal. There was a lot of different companies out there. I happened to go to this company called Elara, Lyra. Got connected to a therapist, met with her for 10 sessions. It was fantastic.
Was she around the same age as you? Because I always wonder, like, do you want your psychiatrist to be someone who, I guess, could put themselves in your shoes, or you could see themselves putting themselves in your shoes and it's relatable, so you trust the advice a little bit more?
Yeah, she was around my age. I think that certainly helped, especially what I was going through with my own romantic relationship disaster. And yeah, it definitely helped to get perspective. And she just had a better handle on modern romance and modern relationships. Nothing
Yeah.
the other two didn't, but they did not generate confidence.
Switching gears here a little bit.
Diana's dying.
I'm really curious to see your take on ADHD and sort of the prescription of Adderall and all. I also know that I think that Adderall is in short supply right now. There's like a lot going on with people not being able to get Adderall. I also feel like there's never been more conversation around ADHD. And some people feel like it's being overdiagnosed. Some people feel like it's being underdiagnosed. What's kind of your take on that?
Yeah, it's a good question. It keeps coming up over and over again, and everything is in short supply. There's a theory that for the longest time, ADHD was underdiagnosed. And now we're finally catching up to appropriate diagnostic numbers, let's say. I guess I kind of believe that halfway. It seems as though a lot of folks are struggling to focus, to maintain attention, that have low mood. And as far as strength of medications that we have in our arsenal as psychiatrists, as mental health providers, as doctors, stimulants are up there as far as bang for your buck. They do have side effects, but as far as something that you're going to give to someone and they're going to feel the effect right after, and it's going to be a pretty profound change in just their disposition, stimulants are strong, straight up. So nowadays, everyone's looking for substances, treatment, medications to work quickly. And I think stimulants offer that more than other treatments. I think we're now entering a territory, this is a long-winded way of saying, I think now we're kind of edging towards over-diagnosing.
Over-diagnosing and over-prescribing. I just think back to friends I've had that have been prescribed Adderall since they were teenagers. And I think that it's had an impact on them. Like, from a mental health standpoint, like, they just feel a bit more muted than, say, they were since they've been on these drugs for at least a decade. Like, are there any studies that have looked into this potential impact of just being on these drugs for too long? Like, can you just maybe go on it a little bit or just use it, when you're really having trouble concentrating? Does it have to be every single day?
I wish there was. To my knowledge, which albeit is not completely comprehensive, I know what I know and I know what I don't know. I am not aware of any longitudinal study looking at the long-term effects of stimulants on your health. I think you're getting at something big, Elara, that I think there's a lot of negative consequences. Case in point, we recommend patients to take what's called stimulant holidays. So obviously there's something not great if you're recommending that they take holidays when they don't need it. You don't recommend that for blood pressure medication. So yeah, there are some, it strains the heart. It can make you more irritable. It can affect your sleep. When you take it, really matters. So it's not for everyone. There are a lot of side effects that are way more intense than people realize.
It also seems like, and please correct me if I'm wrong, that I feel like for other mental health issues like anxiety or depression, there's a go-to of like sleep, stress, community, all that kind of stuff. And for ADHD, it seems like the big push is like just take medication rather than what are things that we can do to kind of support you outside of medication. Is that true? Or is that just kind of the like idea or perception behind it?
It's definitely the reality. There are behavioral interventions that you can provide to folks with ADHD that can really help with organization, help with task management, help with just getting things done in general that just don't get emphasized because it's way easier just to prescribe a medication and to hope for the best. And it's less work for the patient. So for all those reasons, we are now in this situation where all these meds are out of stock at pharmacies.
That's wild. I think that for ADHD, in my personal experience, I think I have a little bit of attention deficit at times, and consistently working out really helps me, right? Like going back to your whole recommendation of, breaking a sweat every day, and then also getting some good quality sleep to help reset for the following day is very helpful, like across the board in terms of just regulating your mental health. Are there any other tips besides the, get good quality sleep, break a sweat that you'd say you'd recommend to kind of keep your mental health barometer nice and even keeled?
Actually, yeah. One thing, when things are going well, a lot of times visits will be quicker when I check in with folks, which is fine. When they are going well, I'll encourage that client, that patient to take a snapshot. Like, okay, I'm glad things are going well. I'm glad you're feeling a lot better and you're chugging along. Take a snapshot of like what is working right now. Like what is your recipe? What is your blueprint? Because something's going to happen. Unfortunately, it's another guarantee that I say, like, I guarantee that life's going to throw you some bullshit at some point. Like, how are you going to deal with it? And then we can think back to on even today. So like March 13th, you were feeling great. What was working? Let's go back to that. So staying attuned to what works for you and trying to get back to that when things deviate.
Yeah. I've become a big fan lately. As you know, I had a baby 2.5 months ago. So sleep is hard to come by. Stress is, running higher than it was 6 months ago. What's helped me on a day-to-day basis to kind of maintain my baseline is taking moments and thinking about like what I'm grateful for. So practicing gratitude has been a huge, huge thing for me.
So you're taking a page out of the positive psychology book, which I think is awesome. Focusing on the positives and really working towards a mindset shift.
Matt, do you have any books that you recommend to people? Like any favorite books for people maybe listening who, if they're wanting to improve mental health, but maybe don't have the resources to go to therapy?
Yes. I'm not sure why this one was coming to mind, but I'll mention it. Thich Nhat Hanh. Have you ever heard of this? His book on anger is tremendous. Everyone gets angry, right? And typically there's something beneath anger when we feel it. And his book helps you to get at that. I just found it pretty eye-opening.
I think that my brother-in-law read that book, and I have to say I noticed a bit of a difference in him afterwards.
It's really good. I also like, not maybe books, but if y'all like podcasts, I love Arthur Brooks. He is I think a PhD researcher at Harvard, writes for The Atlantic. He has a great column, and yeah, I recommend it to everyone. One of his points that I actually use a lot with patients, I'm not sure if it was him, hopefully I'm not miscrediting it, I guess just in the idea of happiness, because happiness comes up a lot, right? Meet with a doc because you're not happy. I always encourage folks, and I got this from one of the blogs, that happiness is to have a mindset shift, that it's more of a direction, not an endpoint. If you can make that simple shift, it'll go a long way, because like emotions, sadness, happiness are totally normal. If you were happy all the time, that'd be super weird. So if you just trend towards it with some blips, you're going to be way better off.
I love that perspective. So kind of wrapping up here, I don't know if Elara prepped you or not.
No, we're hitting him blind. I didn't give him any...
No idea what's coming.
Yeah, he does know what's coming.
Always ask our guests 2 questions. The first question is, what is a lesson that you have had to learn the hard way?
What am I going to go with? I have a couple that are coming to mind.
You can hit us with a few.
Some people give us a few.
Okay, first one, everything is temporary, which is good and bad, right? You're going through a tough time, a shit time. It's temporary, hopefully.
Right.
It is. Everything's temporary, so it has to be. But if you're going through a good time, it's temporary. On the same lines, like relationships change, and that's okay. It's the nature of them. So that has helped me to push through some challenging instances. Another life lesson, I guess a lot of these are related. Another one, when people show you who they are, take note. Don't ignore it. Like, I think it is great. I tend to have a positive view of people. I'll give people a lot of chances. But if they show you who they are through their actions more than their words, take note.
That's a good one.
That's a hard one.
That could be a whole topic in itself as far as a podcast, right? Like how to actually be able to read, someone's sense of self and who they actually are, right? And people that are able to mask that.
Because you're trying to have an open mind. I think it's great to have an open mind. At the same time, when the reality is right there, pay attention. People can change, right? You can give them a chance to change. But once again, you're going to pay attention to that change through what they show you.
Actions speak louder than words.
There you go.
So now kind of other side, flipping the coin. What is a mantra for Nike, for example? It's just do it. What's a mantra, some piece of advice that you've come across from a family member or friend that right now is really helping you?
this is kind of a lame one, but I have to tell it to myself a lot. Focus on what you can control and not sit outside of your control. It helps me to, sometimes I get overwhelmed, but it helps me to minimize that to a certain degree, because you can't do everything. Your powers are limited. So just do what you can do.
I don't think that's a lame one. I think that that's like a really, really, I was just reading something about like being afraid of Elara, the stage that you're in, about the sleepless newborn nights. And the advice was that, like there's nothing that you can do about it right now, and to just enjoy, and like when it comes, it'll come. And I feel like you can apply that to any moment that you're in life. And it's a really important lesson.
Yeah, there's only so much you can control, and you can drive yourself crazy trying to figure everything out around you. But at the end of the day, you're only driving your car, not everybody else's on the road. Well, this has been a really fun conversation, Dr. Matt.
Thanks for having me, guys.
Do you call him Dr. Matt at like family dinners?
No, it felt right in this moment.
Yeah, I get that from a few people. I have some friends that call me that, kind of like
Dr. Matt.
Cheeky.
So, Dr. Matt, if people maybe wanted to see you or work with you in, say, a therapy capacity or with work, how could they find you?
I am in the process of creating my own website. Stay tuned for that. You can find me on that website for providers that I mentioned, called psychologytoday.com. Just search my name, plug it in there.
Where are you able to see patients from as far as states? So
I am able to see patients. I'm licensed in Massachusetts and in New York, and soon to be others in an outpatient setting. So let me know. I'm also at McLean Hospital, not going anywhere, here most days, all day. No, it's good. I love it.
Awesome, Matt. Well, thank you very much. If anyone has questions, drop them in the comments, and we will all see you guys next time.
Sip, savor, and live well with new episodes of the Matcha Guardians every Wednesday. Follow our show for free on Apple, Spotify, YouTube, or wherever you're listening right now. Leave your questions and comments below. Find us on Instagram at The Matcha Guardians, or click on matcha.com.